Okay, welcome to another episode of the Regenerative Health Podcast. I'm Dr. Max Goldhain, and today I'm talking to Dr. Jackie Montefiore. She's a general practitioner and metabolic health doctor who has an interesting background, having previously trained in nutrition and dietetics. So, Jackie, thanks for coming on the show.
Yeah, great. Thanks for having me, Max. Happy to be here.
Great. Can we please start with a bit about your background and particularly your training first as a dietitian before you came into medicine?
Yeah, sure. So my undergraduate degree was in nutrition and dietetics. So that was a 4-year degree. Didn't really know what I wanted to do coming out of school. Had an interest in physiology and kind of medical side of things, but so found myself in nutrition and dietetics, and so it's quite a comprehensive degree. And following that, worked in that area for a number of years, about 5 years, I think, before deciding to go back to uni and study medicine post grad. But it was interesting. Some of the roles I had as a dietitian were involved in weight management, amongst other things. And it's really quite interesting, I'm sure we'll get to this, of how my thoughts have changed about body weight regulation and how we can manage it. So it was definitely a very handy degree to have before doing medicine, and not least at all for the practical aspects of being able to talk to patients, counselling patients, a bit of familiarity with the hospital type of system. So that was all very useful then going in and studying medicine and subsequently becoming a GP. But yeah, it's really interesting now to look back on some of the material we covered in what was largely the medical nutrition therapy, and where that came from, and the consequences we now know of that stuff that we were taught, which I think, by the way, is still being taught to dietitian students even to this day.
Yeah. And you're obviously a low-carb practitioner, meaning that you're helping to reverse your patients' metabolic diseases, specifically with whole foods, real foods, low-carb nutrition. Can you explain how or what you were taught initially in dietetic school, and maybe a bit in medical school as well, and how does that differ to what you're guiding and your patients through currently?
Yeah, well, the second part of your question's pretty easy, in that we were taught essentially nothing in medical school, so no instruction on nutrition at all. I've heard some people say that their medical degree, they had half a day on nutrition. No, we didn't even have that. So that one's easy. And then obviously it didn't bother me too much because I'd had a background or a 4-year degree in nutrition and dietetics, but I'm sure a lot of my student colleagues will probably worse the wear for that. But my dietitian training was obviously quite, guidelines based, conventional based, geared towards the food plate, or some people might be more familiar with the food pyramid, as really, the cornerstone of our advice of what we should counsel people when we're giving them nutrition counselling. And that was back in the late 90s and early 2000s I was studying. So that was really pretty much the peak of the time that lots of carbs were recommended at their base of the pyramid, or the large proportion of the food plate. And so that's very much what we were schooled in, is that those were an essential part of everyone's diet. It was kind of sort of sold to us, I guess, that those foods were quite nutritious, and we needed the fiber and we needed some of the B vitamins in them, as part of, the other food groups we were taught about. But certainly with regards to fats and saturated fat in particular, that was very much frowned upon, to try and minimize it as much as possible. We're always taught that the person's intake should be less than 10% saturated fat, and their overall diet should be no more than 30% total fat. And yes, very much taught to us that any increase in your intake of saturated fat is going to increase your blood cholesterol and therefore increase your risk of heart disease. And with heart disease being a major cause of death and disability to adults in Australia, this was very much the cornerstone of what we were taught in nutrition school.
Yeah. And I mean, anyone who's listened to previous episodes of this podcast will know that I think that the current dietary guidelines upon which most people are basing their diet are very much misguided and responsible for a lot of harm in the form of people intentionally trying to make good dietary choices, but simply using incorrect and misguided information that is honestly having quite significant and long-lasting negative health consequences, particularly with the development of metabolic disease and cardiometabolic disease. So how, in terms of now where you're sitting, Jackie, what each aspect of what you just mentioned with regard to the saturated fat phobia, the emphasis on carbohydrate intake, where are you sitting now with regard to those key foundations of diet, and what are you advising your patients?
Yeah, so obviously my views have changed significantly since the days that I studied nutrition and dietetics at uni and in those first years working as a new grad. And that, like many doctors and clinicians who practice in this space, that largely stemmed from our own, my own experience with implementing a lower carbohydrate type of approach to address my own health issues at the time. And for me, it was around the time of pregnancy and just in that post-pregnancy period where I believe my metabolic health was starting to struggle. I gained far too much weight in pregnancy. It was very, very close to having gestational diabetes. Had very, fairly large babies that probably, technically did have GDM myself. And then after delivering my first, finding it very difficult to control weight and, somehow came across the concept of a lower carbohydrate approach. I don't know, just on the internet somehow, and mainly through hearing the story of Gary Fettke, who's the orthopedic surgeon in Tasmania that you're probably aware of, Max, who got into trouble from the DAA or the Dietitians Association of Australia, complained about him, and having previously been a dietitian myself, that quite piqued my interest of what was going on for them to complain and to react so strongly to what he was advising. And so I looked into what he was advising, and I knew with my knowledge of human physiology that it actually made a lot of sense. And that then sent me down a very big rabbit hole that I'm still burrowing through at the moment, looking into just re-looking at the science of the nutrition advice that we've all been taught, those public health nutrition messages, and then that more detail than that I, as a dietitian student, learnt. So it basically prompted me to look more closely, so to scrutinise a bit more that the scientific basis of those recommendations and where that came from. And because, when you're a 19-year-old dietitian student, you kind of just want to say what needs to be said to pass your exams and get through the degree without kind of questioning things too much, or at least that was my position then. So to sort of go back, years after graduating and relook at all that and realize the flaws in what was taught and a bit more of the history about it. I don't know, Max, if you've read Nina Teicholz's book, Big Fat Surprise. Have you read that one?
Parts of it, yeah.
I just found it fascinating, having been a dietitian student before and just going back over that history of the guidelines and why we are where we are today. And so that was also a huge eye-opener for me. So the short story is I came to realize that on a number of levels that what we were taught didn't make a lot of sense. And my personal experience with going against those guidelines resulted in quite significant subjective improvements in managing my own weight, but also subjective feelings of better energy, lower IBS symptoms. As it turned out, I think an improvement to my own fertility later on, with third pregnancy. So, yeah, lots of personal benefits for myself. And then from there, once I had satisfied myself it was a safe thing to advise patients, and knowing, obviously I had that nutrition background, feeling quite comfortable discussing nutrition with patients. I was a GP registrar at the time, so training to be a GP, and started to incorporate it into my practice at the practice I was training at the time. And found that a lot of people responded quite well to fairly straightforward, like I had a one-page document I would give to patients. Obviously, any sort of lifestyle change is challenging for a lot of people, but I was quite surprised at the amount of people who would kind of just take that away and run with it. And I'd see them, 1 to 3 months later, and they would just, have lost weight, say that they feel fantastic, and seeing all their blood pressure and metabolic markers improve. So that's sort of really reaffirmed to me that this way of practicing, of adding this nutrition adjunct to my medicine that I'm advising people, was very safe and very empowering for my patients.
Yeah. And I want to emphasize for the listener that the approach or the paradigm shift that we're talking about specifically is reversing this idea, and I would call misinformation regarding the harm of consuming animal fat and saturated fat and dietary animal-derived sources of cholesterol. That was for many years promulgated as truth and dogma, and has subsequently been completely debunked. In addition, we're talking also about the misguided advice that we need to somehow base every single meal on large number of carbohydrates. And again, talking about the industry influence on those type of development of those guidelines, there was clear industry influence from agricultural industries, particularly in the United States, and countries around the world simply just followed the United States in mimicking in taking upon those guidelines. And Gary Fettke, I mean, I've talked to him before in this podcast, and as you mentioned, he was brought before the medical board for inappropriately reversing his patient's diabetes. And another fascinating rabbit hole, which is what his wife Belinda kind of discovered, was that there's very, very deep-seated influence from religious groups, particularly the Seventh-day Adventist Church, who have influence through their companies such as Sanitarium and Uncle Toby's. So, I really like how also your own health journey was the prompt to basically change yourself and then change your practice. And again, that's been a common theme with all the metabolic and low-carb practitioners I've talked to so far, is that everyone seems to have had that event or that stimulus to turn the mirror on themselves and then question a whole heap of beliefs. Have you looked
Believe
into
me,
that?
I was very skeptical. Sorry, Max.
Really?
I was very skeptical. Believe me, at first, I kind of had that mainstream view, like, this is, a fad. This is like Atkins. It's very dangerous. Look, just for a laugh, I'm going to try it out and just see how terrible I feel. And was quite surprised to have my own N=1 experiment go the complete opposite direction that I predicted.
Yeah. And look, it's almost, we're in this odd position as doctors who are following an evidence-based scientific model, who are essentially telling our patients that you've been misled. And it's almost, we're not conspiracy theorists. We're simply analyzing and presenting what is basic biochemistry and physiology, interpreting it in best practice kind of way. But it's interesting and fascinating that kind of this is the position that we're in now, that we're basically telling people, hang on, don't do what you've been told for so many decades.
Yeah, and that's exactly what I say to my patients, Max. I say to them, you almost have to imagine you were born yesterday from a nutrition knowledge point of view and kind of completely unlearn everything that you thought you knew about nutrition, because almost everything, even other things, not just the saturated fat story, but, about salt and fiber, there's much more to it than what we've been led to believe. So,
there are layers. There are layers of interwoven and overlapping pieces of misinformation. As you said, the harms of cholesterol, salt and its relation to diet, consumption of carbohydrates, red meat. I mean, It's a very, very, very deep rabbit hole. And I want you to get your idea, because you obviously treat a lot of patients from a metabolic point of view. Can you define for us and the listener what is metabolic health and what is metabolic ill health, and what do you look for, and what are the kind of signs and symptoms of someone who might not be metabolically healthy?
Absolutely. So, like everything in medicine, we always start with the history. So, I get a lot of information from hearing people's, dieting and weight history. And a lot of my patients I see are kind of perimenopausal women. That would probably be my main patient demographic. So you can, get this feel of if people have done a lot of the traditional calorie controlled approaches like Jenny Craig and Weight Watchers and all that sort of stuff. So that is one part of the history I really pluck out. Another thing that's interesting is this description of that I listen for of hangry. So getting hangry in between meals. And I think everyone knows what hangry means, a kind of combination of hungry, and you get irritable as well. So you get a bit angry. And to me, that flags that blood sugar dysregulation and being on a blood sugar roller coaster. So I'm always listening out for that. And then, of course, with their medical conditions that they currently might be experiencing. So if there's an element of hypertension, I ask them for women, again, who are probably my main population base. I ask them about their pregnancy history, if they've had pregnancies, did they have struggles with gestational diabetes? Are they known to have PCOS? So they are all reflections of metabolic dysregulation around that time of their reproductive years of life. And then also an increasing difficulty to control their own weight, which says to me this evolving insulin resistance has probably been happening to them through their adult life, that coincides with the tendency to gain weight around the midsection in particular. And just finding, they say in my 20s and early 30s, I could control this. I could, if I gained a few kilos, I could easily bring it back down by just, having a few less biscuits and walking a bit more. And all of those measures just don't work for me anymore. And why is that? And it's because that much more water is under the bridge. They've probably become a bit more insulin resistant. And so their body is just less metabolically flexible to be able to tap into its own fat stores because of that dysregulation of insulin. And I'm happy to explain any of that further. I know that's probably a little bit technical.
No, that's great.
Yeah, let me know if you want me to flesh out any of that.
No, that's fantastic. And I really like this idea or the concept of identifying people's emotional, often also quite emotional roller coaster that follow the blood sugar highs of eating sugary and processed food, and then the corresponding lows when you get a big dump of insulin in the system, and there's an energy crisis, and the second foray into the cupboard occurs to kind of patch up that roller coaster. And look, that is someone, or that is a common story of people who are basically in a very, very carb type glucose metabolism state, and they're completely unable to access their body fat. And in terms of the test that we would see when a patient like that comes in front of us, what are your favorite tests for identifying metabolic dysfunction?
Yeah, absolutely. So So when I've still got them in the room, obviously checking their blood pressure and their waist to height ratio is an important parameter as well, as part of the examination, and tells me a lot about their metabolic health. And so then usually I'll order some baseline bloods if they haven't had any all recently. And that's just kind of the standard. I just usually personally start with the standard ones that Medicare will give a rebate for, in terms of what's recommended in our GP red book to check for, screen for cardiovascular health. So that's fasting lipids, fasting blood sugar. I'll usually also, add a liver function tests and their electrolytes. I do also add a few others that aren't commonly done by most doctors. So I'll often test for fasting insulin as well. And the rest, any other tests would be guided by what symptoms the patients are experiencing. So for women, often I might check iron if there's some history of tiredness or, fatigue or anything like that, thyroid function occasionally. But those metabolic markers I just mentioned are kind of my core set of things. And we get a lot of information out of that. And so I normally offer to patients, let's check those ones that Medicare will cover initially, because really it gives us a lot of information to start off with. I attract a lot of patients who are very interested in this field and have done a lot of reading and listening to YouTube videos and stuff, and they might be interested in some of the more advanced markers. So I'm happy to facilitate testing for those as well. But we do get a lot of information out of those basic tests that we can organise through Medicare first. So I usually do those as bloods initially. Another test I do like to do is a DEXA body composition scan to quantify, primarily I'm trying to quantify visceral fat with that scan. So as something to track over time, because most people see me with concerns about weight and they want to lose weight, of course. And so by capturing that baseline DEXA and their visceral fat, we can watch their visceral fat come down over time, which is the thing that's most closely associated with all the health risks that I'm interested in having them avoid, being your type 2 diabetes, cardiovascular disease, high blood pressure, strokes, etc. And track that over time and simultaneously making sure they're not losing too much muscle mass over time, because we want people to hold on to their metabolically active muscle tissue.
Great. Yeah, that's
so those are the main ones that as a baseline, Max, and then others would be guided by their, what I find, if I do more heart tests, that would be on an individual basis.
Yeah. No, I really like that. And I think that the body composition and identifying this high-risk visceral adipose tissue is a really, really interesting and key point here. Because to the average patient who have maybe been following the mainstream narratives around obesity for a very long time, everyone seems to be of the opinion that it's the absolute weight that matters. And simply, eating less and moving more will reduce weight, and everything is a sequelae downstream of weight loss. But what we're saying as metabolic doctors is it's not only the absolute BMI and the amount of weight you're carrying, but it's specifically where that weight is. And the high risk weight being that visceral adipose tissue, which is going to be reflected in things like a raised waist circumference, all the markers of metabolic syndrome, like you mentioned, high blood pressure, abnormal atherogenic dyslipidemia, high blood sugar, high fasting insulins. And so the DEXA scans are really great idea. And I imagine that patients would love to see a before and after DEXA scan to really visualize their progress that they're making.
Yes. And we do see some really impressive progress scans where we can see their visceral fat come down beautifully, and when they've really embraced the resistance training as well, which is an important piece of the puzzle, they're holding on to their muscle tissue nicely. So, yeah, it's quite impressive and rewarding.
Fantastic. I want to tackle a little bit to pregnancy, and you alluded to initially a little bit about your own journey with perhaps gestational diabetes. And for the listeners, gestational diabetes is a state of insulin resistance associated with pregnancy and being pregnant, related to the placenta and all the hormones of pregnancy. I like to think of it as an early warning sign and a bit of a flag that, hang on, you're likely to carry some predisposition for metabolic syndrome later in life. What's your approach to to gestational diabetes in general, and specifically maybe trying to identify the women who are high risk before they get pregnant?
I must admit, I would feel quite lucky if someone does consult me antenatally, because we know, a significant proportion of pregnancies are unplanned. So I feel in quite a privileged state, and every now and then people do. And yes, I mean, when you think about it, the baby's sole nutrition is clearly coming from the mother, to change from the tiny little, single cell embryo, which quickly grows into a full-term baby over this 9-month gestational period. So it's really quite miraculous when you think about it, and everything that goes into that increase of that little baby is brought in by the mother's intake. So it's just so vitally important. And it's, again, another very confusing area for people and including myself when you're looking at the nutrition advice around pregnancy, and because there's a few other things that are layered into that advice. So, for example, I, in my first pregnancy, was always quite paranoid about listeria risk, which is a type of food poisoning that can have quite dire consequences for pregnant ladies and their babies. So, increased risk of miscarriage, stillbirth, poor pregnancy outcomes. So, my first pregnancy was an IVF baby, so it was very sort of heart-fought pregnancy, and I was just terrified of doing a foot wrong and compromising the pregnancy. So I was quite worried about listeria, which, looking back now, was quite unfounded because it's very rare. And when you follow the nutrition guidelines to reduce your risk of listeria, it's really getting rid of a lot of healthy, natural, unprocessed foods, or being a bit scared of them. So that's things like, eggs that might be slightly undercooked in the yolk, salad, green leafy salad vegetables, that sort of thing. So I ended up, and I think this is why I almost gave myself gestational diabetes. It's kind of going for like the safe, food safe option of quite a lot of hot chips. So this is before, recognizing the extent of how concerning that was. But it's really quite interesting when you put that into perspective of how common things like macrosomia, so that's a large birth weight baby, gestational diabetes are compared to a poor pregnancy outcome from listeria. It's like night and day, the difference in risk and the numbers that we're looking at here. So we really need to put that into perspective. And I just say to patients now to be sensible with the food choices. Don't eat food that is been sitting there for a long time or could be a food poisoning risk. If it's all freshly prepared, it should be fine. But we don't need to have that degree of paranoia about some of those nutrient-dense, healthy, quite often animal-based foods that, we've sort of had the fear of God put into us about from a listeria risk in pregnancy.
Yeah, no, that's a great point. And the trade-off, there's always a trade-off. I mean, people don't really get informed of the fact that every decision is going to be trading off something. And if you're ignoring or you're eschewing very, very important nutrient-dense foods, then for the small risk of foodborne illness, then there's consequences to that. So someone is gestationally diabetic. Would you say was your first line treatment low carbohydrate diet, or how do you approach that specifically?
For gestational diabetes, so yes, look, I think you mentioned Lily Nichols before, and I think she has fantastic resources on this topic. And essentially, any young lady that comes into me who's planning pregnancy or even mentions that, I point them towards Lily Nichols's books and blog website as an excellent source. And essentially, she advocates for a whole unprocessed foods diet or way of eating, if you will. And what that does is that it's delivering all those crucial nutrients in the most bioavailable form that the mother can absorb and be used to, as building blocks for the fetus who is developing. So I always point people towards her resources. She has them meticulously referenced. I understand she had an influence on changing some dietary guidelines in some Eastern European countries to do with their approach to gestational diabetes. So it's more and more being recognised and accepted. It's quite slow though, that happening here in Australia, and you'll still hear that conventional advice of, yes, you've been diagnosed with gestational diabetes, so we can see that you haven't tolerated a 75-gram load of glucose. But despite that, we're going to get you, encourage you to have a high carbohydrate diet that's far in excess of that tests that you did,
Yeah.
and then wonder why your blood sugars aren't in control, and add medicine. So, when it was put like that to me, it was just an absolute epiphany. It's just crazy. And but that's still the state of affairs. So I will, encourage my pregnant patients to have a look at Lily Nichols' resources. I think slowly more and more clinicians, because obviously ideally once they've got that diagnosis, they are a bit more obstetrically complicated and at high risk. So they're going to be under closer scrutiny of their obstetrician and midwife team, and sometimes might even have some diabetes team involvement, depending how bad it is. So, the more players come into the play, the more conflicting nutrition advice they're going to get. So I just literally state my case and offer to monitor them. And obviously they're having their monitoring scans and pregnancy examinations and all that sort of stuff through the pregnancy. And in my experience, women who have eaten that way have had excellent pregnancy outcomes, delivered very healthy babies who are thriving and then eat and, do all the things that little newborn babies should do without any concerns that they haven't had enough carbohydrate during the pregnancy, despite that their mums haven't consumed what is recommended, and it's worked out very, very well.
Yeah. And I'd like to make the point that there is no such thing as a carbohydrate deficiency in pregnancy. I mean, eat high quality sources of carbohydrate like fruit if you're not metabolically unwell, but the liver particularly has an ability to synthesize what you need in terms of glucose. I'd like you to speak a little bit about foods, particularly foods in pregnancy. We alluded to it a little bit before, but the kind of foods that we're thinking about to grow this baby, which I like to think about as functionally parasitic upon mum's nutrient stores, are the most nutrient dense and bioavailable foods. So what type of foods are you advising, or would you recommend someone to be consuming, perhaps even before, but especially during their pregnancy?
So at different times, there'll be other limitations. So anyone, who's been through pregnancy knows that the morning sickness issue can be problematic and really change what foods you feel like you can stomach. So that's something to keep in mind. But I say to my patients, as much as possible, to try and focus the foundation of what they're eating on natural, whole, unprocessed foods. And I discuss some of the nutrients that will be contained in them, which I'll cover shortly. But things like eggs, meat, fish, chicken, veggies, a bit of nuts and seeds, full-fat dairy. I say as much as possible to base their intake on that. Yes, a bit of fruit is fine for most pregnant ladies. And so, as much as possible, eating that way. Symptomatically, there's some nutrition strategies we can use to help lessen morning sickness and reflux and other symptoms they might be experiencing relating to pregnancy, constipation as well. But basically what eating that way it does, and Lily Nichols' material really brought this to my attention, is that it's really providing the growing baby with those essential nutrients that really many of them can only or mainly come from animal sources. As as controversial as that might sound these days, it's kind of just a physiological fact, and that's things like B12, iron, zinc, some of the omega-3 fatty acids like the DHA. Choline is a really interesting one. It's a nutrient I had only relatively recently heard about. It's very vital in fetal brain development and also placental development. It's thought a lot of pregnancy complications that occur late, in the third trimester of pregnancy are relating to placental dysfunction. So, things like preeclampsia, as an example. So, having optimal placental function also makes a lot of sense, and choline is a nutrient that is really vital for that. And a really rich source of choline is egg yolks. And so, I have this joke with my patients that eggs are my favorite superfood. They're just, have so many benefits about them. And I tell my patients it's not possible in my mind to eat too many eggs. There is no upper limit. I'm happy for them to eat as many as they can tolerate. And so eggs are fantastic, but also other animal sources. So especially slow cooked meat dishes, where there's the bone and the connective tissue, which might be slowly cooked as well, then unleashes a lot of those nutrients that are very vital, things like glycine and collagen and gelatin and other amino acids, zinc. So there's a whole bunch that I could rattle off. So having those healthy animal sources, and then the other supplementary foods you might want to add in. We've all heard about folate and having the green leafy veggies as a folate source, so that is important as well. And then a lot of those are also adding in iron, and iron being a main nutrient of concern in pregnancy. The iron demands are very, very high to grow a new little person. So many pregnant and non-pregnant women I see are iron deficient. It's endemic. It is so common, and and I think that's due to a few factors, the nature of our diet, but also I think less than optimal gut health and absorbing the iron plays a role, I suspect, as well. So sorry, I'm kind of gone off on a bit of a tangent there, Max, but did I answer your question?
Yeah, no, that's fine. And that's great. And I really want to emphasize the point that the sources of animal food, or the source of nutrients, are predominantly animal based. As you mentioned, choline. So eggs are an incredibly rich source of choline, and not only for placental development, but also for the prevention of neural tube defects, in addition to folate. So it's not only one molecule, the folate, that is going to help you prevent neural tube defects. It's the constellation of all these nutrients in aggregate, and of which eggs is such a good source. Meat cooked on the bone Absolutely. Is another amazing source of nutrients. You mentioned glycine. You mentioned all the collagens. There is some evidence, I believe Lily's talked about this, of these type of amino acids being conditionally essential during pregnancy, and for particularly babies growing soft tissue, babies' joints, but also the fact that the uterus and the placenta is developing so rapidly, so quickly. I mean, it's like you're growing a new liver in a matter of months. So the fact that you can get by if you don't eat these foods, but the outcome, in my mind, is going to be nowhere near as optimal if you include some of these foods. I want you to talk a little bit about liver, because liver is, in my estimation, the optimal human food, in that it contains the absolute full spectrum of fat-soluble vitamins, A, D, E, K, a particularly good source of K2, as well as all the B vitamins and minerals like zinc, heme, iron, particularly those two. So what's your opinion on liver, and what's your advice on consumption of liver during pregnancy?
Yeah, liver is an interesting one. It's not a commonly consumed food in our culture, unfortunately. It has kind of, probably was back in the day, but has fallen a bit of the wayside. A lot of people are a little bit queasy at the thought of consuming organ meat. So it's definitely less culturally acceptable. But from a pure nutrition point of view, even in my kind of 90s based nutrition degree, it was always at the top of the list as the most richest source of all the B vitamins and most of the vitamins that we learnt about at the time. So there has been some concern voiced about pregnant ladies eating liver for risk of vitamin A toxicity. So as you said, Max, liver is a very rich source of some of those fat-soluble vitamins, and the concern is with getting too many of those is that we can develop a toxicity in the system. But really, when you look at that in a bit more depth, those studies, touching on with vitamin A in particular, toxic levels have been, linked to fetal malformations and quite serious consequences. So it is serious stuff that we're talking about here. But those studies were linking back to synthetic vitamin A in supplemental form. And as you say, natural whole foods, they've got the right combination of nutrients in the right form, and they work together synergistically to counter some of the, potential negative effects of too much vitamin A from having liver. But it would be very, very hard to consume the amount of liver that there would be concern of vitamin A toxicity. And we know from the studies that vitamin A deficiency is actually far more common in pregnant ladies. So it's a bit of a disproportionate concern about consuming liver and a concern for vitamin A toxicity. I have never heard of this happening in practice, and I think primarily is because not that many people consume liver. But because of the nature of my practice, I do tend to attract patients who have already an interest in that area and ask me about liver, and quite happy. You can get quite significant benefits from just quite modest amounts of liver included in the diet, so somewhere in the realm of about 80 or so grams per week. And if you are a little bit queasy at the thought or the taste of liver, there's ways you can disguise it, add it up with muscle meat mince in a meatball, and if it's across a few meatballs, you won't even notice it. But it is definitely a very important superfood, and I agree, one of the optimal human foods to have.
Thanks, Jackie. Yeah, thank you for that explanation. That was very good and very comprehensive. And again, it's harkening back to the theme that we have of whenever you are omitting something from the diet, there's always going to be consequences, and there's always trade-offs. So yeah, you might be worried about perhaps vitamin A toxicity. And as you said, you should be worried if you're consuming large amounts of synthetic retinol, not in the context of real food. But if you decide to omit liver for that reason, then you have to deal with the possibility that you not getting an optimal source of so many important nutrients. And look, I would add the sources of liver that are commonly available to people in Australia, which are ruminant liver, cow, beef liver, and lamb liver. They are not on the same order of magnitude of vitamin A concentration as the carnivore livers, such as polar bear or wolf liver, that were have been associated with these stories of vitamin A toxicity in Arctic travelers and the like. So I think helping people realize that liver is a very, very important food to the pregnant period. I think that's part of this re-education and helping people access this vitality and the health that they kind of deserve and that their ancestors would have definitely been accessing. Thank you again for that great summary. I just want to pivot now to vegetarianism, and you made the comment which I love, and it's very it's descriptive. It's unfortunate, but it's bluntly descriptive, which is that iron deficiency is endemic in the female Australian population, and I imagine around the world in other Western countries it's similar. Talk to me about this. Why is it so common? What are the causes?
Yeah, well, like I said, I think there's probably a number of causes. So iron is an element that is vitally important for a number of health processes, and I suspect for a lot of people, they probably started life possibly in quite a relatively iron deficient state. So they might have been starting from that initially. We know it's very, very common for children and babies to have iron deficiency when they develop symptoms, and we might actually check it. Part of that, I think, is due to too much, sometimes dairy consumption. People consume too much calcium in dairy that can compete with iron absorption, plus the demands of growth of the child mean that they need more iron, and that can manifest with a number of physical symptoms. So I think there's that. I think also the misguided public health nutrition advice and sort of saying to limit meat, and this advice is kind of becoming even more pronounced of the amounts of meat that are being advocated for by particularly some of the plant-based promoting groups, who are quite powerful. They're really advocating for these really small amounts of meat, and so a lot of people including doctors, will just listen to that advice at face value and be, you're hearing more these days about meat-free Mondays and all this sort of stuff. So this really active campaign to actually get people to reduce their meat consumption as if meat is the culprit for all of our woes, which we know that it's not. So, and I mentioned before, I think poor gut health, it has an impact as well. A lot of patients suffer with IBS symptoms, and I think a lot of that relates to a dysbiosis in the gut, in that they've got the wrong overgrowth of the wrong bacteria, and it's inhibiting optimal absorption of nutrients. There's probably at least half a dozen factors that contribute to why so many people are iron deficient. The classic symptoms people will get are tiredness, but it doesn't always manifest like that. And sometimes, people might even be, and this actually happened to me in pregnancy, more at the other end. They sort of feel like they have a lot of energy, but poor quality sleep. Sometimes people can get, restless legs, that sort of thing with iron deficiency as well. So it's not always the fatigue as the symptom, although that is a very, very common one. So it's definitely a very common nutrient to be found low, and with associated consequences. So, always I'm trying to encourage people to eat the rich sources in their diet to try and bolster those up. But sometimes that in and of itself isn't enough to move the needle sufficiently to improve their iron stores. And sometimes I will advocate for some iron supplementation or even sometimes an iron infusion just to bolster those levels.
And iron deficiency anemia, as you mentioned, is associated with a range of undesirable consequences. Postpartum depression is one of them. And the point that you made about children, having a lifelong iron deficiency, well, there would definitely be consequences for development of intelligence in those children. And not reaching their genetic potential for intelligence. It's my belief, and I really liked your breakdown of why you think so many women today are iron deficient. I think that the mainstream narratives have a lot to answer for, not only the guidelines, but also pervasive and persistent messaging about the benefit of going plant-based for the planet health, for your health. And it's a very, very thin layer that you have to pull back. It's a very thin curtain that you have to pull back once you delve into the research and the science to realize that it's not really based on any solid foundation of science or truth. But the consequences are that so many people are iron deficient and suffering because of it. I also want to make the point that no matter how much people might like to think that they don't need to eat red meat, the fact is that the Homo sapiens genetic code and our evolved demand for animal-derived heme iron is undeniable and unrefutable. So whether or not you think you need it, there's 300, 500,000 years of evolution that has a deep-seated need and demand for that type of food. And many people might not even know how well they could feel or what their potential is for thriving in their daily life if they've never actually eaten something like a liver, perhaps. Not uncommon to hear stories of people, feeling quite almost high when they first taste a piece of liver because the amount of nutrient density that they're being suddenly given is quite a novel for their body. So thank you for that breakdown. And what other approach would you say to someone who perhaps has been vegetarian for a long time and maybe not or reluctant to start eating animal foods? What's your approach to that patient, and what would you encourage them maybe in terms of order of introduction of foods?
Yeah, look, there's a lot of layers of when someone decides to be a vegetarian or a vegan, and it's not always relating to just their perception of what is nutritionally the best thing. As you alluded to, Max, there's this whole narrative of planetary health and environmental health, and this perception, which I don't believe is correct, that eating vegan or vegetarian is better for the planet. I think there's a pretty decent case that that's actually opposite to the truth. So you do have to tread a bit carefully because people can be almost religiously wed to their dietary choice. So I'm not out to, get into fights with people. And look, the fact is some people do okay on vegetarian diets if that's the way they choose to eat. So look, I'm not going to insist that everyone is a carnivore. And you got to do what suits you and your cultural background and your family and all that sort of stuff. So I certainly accept that. I don't think being dictative or dogmatic is helpful at all. I just try and keep it quite factual, advance the, some of the material that we've just discussed about the nutrient density and bioavailability of animal-based foods, and that especially, if they're purchased from a reputable and responsible, farming type of environment. There's, no need to have concerns about, animal cruelty. I mean, there's so many different layers that come in with the whole vegetarian thing. And, I'm a mainstream GP, and so I'm always a bit limited with time. So I sometimes just don't even go down into some of those rabbit holes, unfortunately, due to lack of time. And I just might put forward a few little snippets of information. Sometimes that's enough, though, to get the, I can almost see the cogs turning in the patient's mind when I present some of this information. And I know of many stories of vegetarians and vegans who say, I just absolutely craved a steak. So I ate one and I felt so much better. Or they've started to include, they've just almost subconsciously found themselves drawn to having more of these animal foods. And I just think it's their body crying out for that sort of nutrition. So yeah, look, it really depends on their background of why they choose to be vegan or vegetarian. And if there's a lot of ideology there or religiousness, I just kind of don't really open that can of worms a lot, to be honest, and just keep it quite scientific and physiological. And this is how the body uses nutrients and the bioavailability of nutrients and that sort of stuff, just to kind of put it to people. And sometimes I'll try and compromise in a way and sort of see if they would be open to including some eggs, or I've heard there's a thought that eating oysters can be less offensive to vegetarians because there's no something to do with the anatomy of oysters.
The sentience in the nervous system. Yeah, I've heard that as well.
Yeah, something like that. I've forgotten the detail. But so just trying to use any sort of opening to encourage, well, could this be a way to include some of these more nutrient-dense foods? And I just offer them to try it out, see how they feel. And because, everyone eats every day and people are often happy to do their own experiment on food and just see how they feel. And it keeps it very objective. And they've got to weigh that up themselves about how that might fit in then with their other beliefs and what they want to do. But I think it is important to keep that discussion open about, the environmental impacts or the concern about some of the, going really too far down the plant-based rabbit hole and its environmental impacts. So, balanced discussion needed.
Yeah. Well said, Jackie. That's great advice. So the just to finish up, I just wanted to get your thoughts on another common condition or that you might see in terms of particularly among female patients, which is irregular periods. How commonly do you see that? And how do you think about it? And what do you think the consequences are in terms of health and perhaps pregnancy as well?
So irregular periods say to me that there's something, malfunctioning in the, the hormonal cycle or the female reproductive cycle. And because as we know, the normal female cycle is generally a 28-day plus or minus a few days. So if there's this history of, essentially what would be PCOS or polycystic ovary type symptoms, one of which is irregular periods or some cycles that are very, very long. So the person might, go 2 or 3 sometimes months without any period at all, and then it'd be quite heavy. Then they might have a short period. So, that cycle of really significant periods that are all over the shop, plus some other elements of examining them and getting an idea of their history. So the classic example is, a young female who has a bit of a family history of type 2 diabetes. They have irregular periods. They struggle with acne. They struggle with their weight, and particularly weight gain around the midsection. There's a pretty good case that PCOS is really insulin resistance of the ovaries. And there's a very good book that covers that in depth by Dr. Jason Fung and a Nadia something or other, who goes through that in depth about PCOS and insulin resistance. And it really, studies have quite closely linked polycystic ovarian syndrome with developing type 2 diabetes and other metabolic significant diseases down the track later on in life. And like you said, Max, it is a little bit of a kind of a canary in the coal mine, a sort of an early sign when someone is young that there is that tendency to be insulin resistant. But there are some measures that we can put in place to really improve that. And the thing I learned about polycystic ovarian syndrome is that it doesn't always follow the classic criteria that we're taught. And sometimes there isn't much evidence of, say, if we do an ultrasound on the person, many cysts in the ovaries, but I will still have a high index of suspicion that there's an element of PCOS at play, and we'll just manage it kind of similarly as if it was PCOS, in that the cornerstone of that being a diet low in refined carbohydrates and other measures to try and improve that insulin resistance. So, not snacking all the time, consolidating their meal times to allow their insulin to come down in between eating, reduced refined carbohydrates, like I said, and other factors in lifestyle that can help insulin sensitivity as well. So exercise, stress management, optimizing sleep, all those things as well.
Yeah, great. And one more question for you is one of fasting, which is quite a common intervention and tool that we use for reversing metabolic disease, and is very effective in certain people, particularly men. What is your opinion on fasting in women, both premenopausal and maybe peri and postmenopausal?
Yeah, it's interesting. I definitely have a very individualized approach with it. So for pretty much everyone, I'm quite happy for them to do something like a 16-8 fast, pretty much most days of the week. There's some people I do think need to be a bit careful with not overdoing the fasting. And I've seen some, less than ideal situations where someone might be over fasting in amongst a lifestyle that has a lot of other stresses, because at the end of the day, while fasting is helpful in that it can reduce insulin and help metabolic health, there is a point of diminishing returns, and that point is very individual in my experience. And some people who have a lot of stress in their lives, their sleep might be terrible. If they overdo the fasting, I've actually seen it can be detrimental. They might start to lose some muscle tissue and have other bad consequences. Sometimes some of their, blood sugars, fasting blood sugars and stuff go up. So it gets quite complex and not what you would always expect to see. And I think part of that is a stress response. But I agree with you. I think fasting is like some of the extended fasts are better tolerated probably in general by men usually. It's not to say women should never, ever do it, but it really depends on the context and what you're eating to break the fast, because you want that to be very nutrient dense, not just break it with anything. Make sure it's really well planned out to then replenish those cells that have been, gone into that autophagy state. We want to, make sense to me to be giving them the best nutrients to, replenish those cells and when we do go to eat. So if it's done carefully, I think it can be a helpful adjunct, and certainly it helps with some of my postmenopausal ladies to help them get off a weight plateau, adding in some fasting. So, yeah, I definitely use it as a tool. I'm just a bit discerning that I don't sort of recommend everyone does a 7-day fast.
Yes,
without some consideration.
I think that's great advice, and I really like that idea of being very, very vigilant and careful about stacking these type of stresses, because fasting is a form of hormetic stressor. that in the right situation is intensely beneficial and regenerative to the organism. But as you said, if you're layering a fast or even a time-restricted eating period, like you mentioned, of 16, 8 hours, if you're layering that on top of emotional stress or job stress, and as well as maybe coffee overconsumption, or all these other factors, then it would be a very quite possibly make a hormonal wrecking ball, and you might end up having the reverse of the intended initial consequence. So thanks for laying that out. That's great advice. So that's a great place to leave it. Do you have anywhere or any handoffs that you can give people about your social media, or how they can get in touch with you if they want to consult with you?
Yeah, absolutely. No, I didn't prepare anything, but people are welcome to consult our practice. We've got a pretty good team now of clinicians. So I serve a role as a GP. I also talk to people a bit about nutrition, given my background, but we do also have our own in-house dietitian that I use quite heavily as well, just to free my time up a bit. And I let her go into a lot more depth and kind of troubleshooting for the individual. So people are very, very welcome to consult with our practice. It's called Sante Medical, Sante Medical, and we're a GP practice in Paddington and Brisbane. So we, see people locally, but we can also telehealth as well. These days, post-COVID, we have a bit more access to telehealth. Our dietitian can telehealth, and we have a functional medicine doctor as well, which I find very handy. I'm conventionally trained as a GP, but I attract a lot of patients that have an interest in some of the kind of more functional related stuff. So it works in quite well when I reach the edge of my knowledge and ways that I can help people, that I can refer them to our functional doctor. So we have quite a few bases covered to help improve people's health and metabolic health. And we always, both myself and our functional doctor, have the paradigm that it's food and lifestyle first. Like, even in the functional space, all the expensive tests and supplements aren't going to make that much difference if we don't have that foundation correct. And so we put a lot of our energy into getting that right, coaching people through lifestyle changes with our dietitian. And then if we need to, we can layer in, things like medication, a bit more in-depth interventions, more the in-depth functional medicine testing, that sort of stuff. So yeah, people welcome to consult with us at any time. We're welcoming new patients.
Great. Well, fantastic. So thank you very much, Jackie, for your time and for sharing all your knowledge with the listeners.
Pleasure. Thank you for having me, Max.